Welcome to the World Massage Conference.
Hello and welcome to the World Massage Conference. I'm your host, Marla Gold, and Diana Thompson will be joining us today. If you're joining us for the live conference, Diana will be in the chat room to answer your questions as this broadcast is being played. I'd like to thank our daily sponsors and our global sponsor, Massage Envy. When you're happy, so are your clients. You'll find Massage Envy to be a friendly, giving, and supportive environment. Find out about Massage Envy's culture at massageenvycareers.com or like Massage Envy Careers on Facebook. And thank you to our education partner, Associated Bodywork and Massage Professionals. They provide an extensive array of member benefits and exceptional liability insurance. Visit www.abmp.com to discover why over 80,000 massage and bodywork professionals have chosen ABMP as their professional association. Thank you to our daily sponsors, Massage and Bodywork Magazine, Massage Today, BioFreeze, and Bon Vital. Diana Thompson will be presenting today on client health records, need-to-know requirements for today's therapist. The Affordable Care Act, ACA, is shifting U.S. healthcare from a system focused on disease to one that embraces wellness and prevention. Complementary and alternative providers are specifically called out in the ACA as a part of the healthcare team. As a result, massage therapists must meet the demands of inclusion, electronic medical record keeping, HIPAA regulations, and standardized communication with the healthcare team. Find out what you need to know during your SOAP and wellness charting from various perspectives within this new paradigm. Paper versus electronic charting, the integrative healthcare team, HIPAA, payer, and legal requirements. Our presenter, Diana Thompson, is a licensed massage therapist for over 30 years, has a practice in Seattle, Washington, and specializes in post-operative care. She authored Hands Heal, Communication Documentation and Insurance Billing for Manual Therapists, 4th edition, and wrote a regular column in Massage and Bodywork magazine titled Somatic Research. Diana lectures at massage, acupuncture, midwifery, chiropractic, physician, and physical therapy conferences internationally, and is a consultant for massage therapy research with the Research Institute at Group Health Cooperative in Seattle. She is a past president of the Massage Therapy Foundation and the proud recipient of 4 national awards in 2013, including Massage Therapist of the Year, One Concept, and Humanitarian of the Year, Performance Health. Welcome, Diana.
Thank you, Marla. It's great to be here with you all. Well, I'd like to start today really thinking about where we see massage in all of these areas. I'm speaking about the Affordable Care Act in particular, even though it's a North American or U.S. Based initiative, but really it's about a one-payer system in healthcare, which is predominant around the world, especially in Canada, European countries, Australia. So I think you'll find some similarities regardless of where you are. The triple aim is something that's very specific to healthcare in the U.S. in terms of measures of the success of changes in the healthcare reform system. Integrative healthcare is kind of the leading buzzword these days, so I want to be clear about what that means. HIPAA, or HIPAA, is all about privacy and security laws. These are really becoming international regulations. So again, I think you'll find similarities in many countries around the world. Then we'll end talking about healthcare records, standardized communication, electronic healthcare records, and really look at how healthcare reform and privacy and security laws are influencing our healthcare record keeping these days. So here we go. The Affordable Care Act is really a shift in focus from disease to wellness and prevention. And I think massage therapy is just critical here. It's a place where we live. We are experts in wellness and education. We really help people make healthy choices. There was a research project done in Boston with obese Latina adolescents. And what they found was they were teaching these girls nutrition and exercise and really just different ways of living more with a more healthy intent. But it wasn't until they added massage therapy that they got better compliance. So what they found was that if they could increase people's self-esteem and self-awareness, they were much better able to make healthy choices. So we are an obvious addition to this healthcare reform. Meaningful use is really how they're trying to measure this healthcare reform change. So are we really making a difference in the quality and efficiency of healthcare? Again, massage therapy is really key here. What we're noticing with some of the research at the major healthcare clinics like the Mayo Clinic, the Osher Clinic, is that when they add massage therapy into these hospitals and big medical clinics, the patient satisfaction goes way up. People are much happier with their treatment and their care, and even they're finding that there's less readmittance, less complications when people are released from care at the hospital. There's less readmittance. So massage therapy really can play a huge role in helping these hospitals and clinics achieve their triple aim. In the Affordable Care Act specifically, there are some sections that I want to go through with you. Section 2706 is really the most important section in the Affordable Care Act that provides a foothold for massage therapy. It's the non-discrimination clause that really lets insurance companies know that they can't discriminate against different types of providers, that really they have to include everyone who's acting within their scope if they're licensed or certified under applicable state laws around healthcare. So as long as you're licensed as healthcare providers or have a certification that includes you as healthcare, you should be, should is the critical word here, should be included in these healthcare exchanges. We have some existing non-discrimination clauses out there in the United States. Washington has had a non-discrimination clause since 1997. So the law passed in 1996 was implemented in 97, and there were dozens of lawsuits filed against the Office of the Insurance Commissioner when this law became effective, because insurance carriers were just scared to death that this was going to raise prices, expenses, costs were going to go sky high. But that did not pan out, so that was very interesting. In Oregon, just last year, they got a non-discrimination clause included in Medicaid, and this is really groundbreaking. We've never been included in Medicare or Medicaid anywhere in the country. Those are our federal insurance plans. Medicare is for the older adult population, and any person with disabilities is included under that federal insurance. And Medicaid is for those people who cannot afford insurance. So it's a big deal to be included under Medicaid. That's our first step to non-discrimination across federal plans like that. So we'll see how this pans out. It's a brand new law. We have no idea how it's going to be implemented. So we'll see. The Affordable Care Act non-discrimination clause was brought forth by Tom Harkin, a Democrat out of Iowa. He was the key sponsor of the bill. And several people worked on that bill. Janet Kahn was one of them. She's a massage therapist and PhD in sociology. She was appointed to the Presidential Council, Advisory Council on the Affordable Care Act. So lots of discussion went on about how to phrase this section in the Affordable Care Act, how to implement it, what was the intent behind it. So they really wanted to include massage therapists in particular, and wanted it included so that doctors could feel comfortable referring to these complementary and alternative healthcare providers, and knowing that patients wouldn't have to pay out of pocket, that they could be covered by insurance. Of course, when the FAQs were put out by the Human and Health Services Board, they completely disregarded the intent and caused a lot of problems. So, but really all the fears that came about with the Washington plan, they should be looking at these cost-effectiveness research studies and really see that that including massage therapy in particular will not increase healthcare costs at all. So we shall see. In the meantime, I think it's really important for us to look at what motivates us around these anti-discrimination clauses. There's a quote that I just read on hope and optimism by Václav Havel out of Czechoslovakia. He says that we have to do more than hope that something will turn out well. We really have to do something. We need to act and make sure that these non-discrimination clauses are held up according to our intent. He says optimism is not the conviction that something will turn out well, but the certainty that something makes sense regardless of how it turns out. So we need to do more than just hope. We need to be optimistic, and we need to act. Some of the other provisions in the Affordable Care Act, Section 3502, I put these two on the slides together because it's really important to look at when they use the word may and when they use the word shall. So in the first one, that they're saying that these interdisciplinary, interprofessional teams may include licensed complementary and alternative healthcare providers, but under the birth center section 2301, it says they shall include payments to providers administering prenatal labor and delivery or postpartum care in these freestanding birth centers. So how many of you out there practice pregnancy massage and work with a pregnant woman throughout her pregnancy, maybe through her labor as a doula, maybe post-pregnancy, working with postpartum symptoms, depression, working with a baby? All of this should be reimbursable within the Affordable Care Act. So this is a great opportunity for us to really look at how can we get involved in these birth centers and become a part of that, because we should be reimbursed for our services. Some other CAN inclusions. They specifically said that we must develop an integrative healthcare strategy. So on behalf of ABMP, I wrote a letter to the U.S. Surgeon General on behalf of massage therapy. It was probably 5 years ago. An 18-page letter stating why massage therapy should be included in the advisory groups and in the Affordable Care Act based on our longstanding participation with wellness and prevention and in rehabilitation. So it was actually about 8 pages of narrative and 9 pages of research citations. So really there's plenty of research out there that demonstrates that we should be a part of this. The good news is, as I said before, Janet Kahn is a part of that advisory group. Another section is about patient-centered outcomes research. I think this is very important because much of the research these days has been more of a reductive type of research, doing randomized controlled trials on massage therapy, which are not very descriptive of our success. Patient-centered outcomes research is a much broader way of looking at studying the discipline and how we interact with our patients. And Dan Churkin is on that panel. That's a very good thing. Dan Churkin has done a great deal of research on massage therapy specific to neck pain and back pain since 1997. So it's great to have him on that panel. Section 5101 includes the definitions of the healthcare workforce. So we are included in the definition of healthcare as a CAM provider. And so I keep using the word CAM. It doesn't ever say massage therapy in particular in the Affordable Care Act, so we need to look at how do we fit into this. What is the definition of complementary and alternative medicine, CAM therapy? So it's whatever is used outside of mainstream Western or conventional healthcare for specific conditions or overall well-being. Complementary referring to something that's used alongside of conventional medicine. Alternative referring to those things that are done instead of conventional medicine. What I love is the second quote. So this is taken right from the NIH website, the National Institutes of Health, which is similar to NCAM in Canada. So this says that many of the alternative treatments are becoming conventional, such as guided imagery and massage. So they actually use massage as an example of something that used to be considered complementary or alternative and are now considered a part of conventional healthcare. Kind of exciting. Integrative healthcare or integrated medicine is defined here on this slide. And what I want to point out specifically in this definition is that they're including healthcare that's informed by evidence. So we really need to appreciate the amount of evidence that's becoming available on massage therapy. We would not be able to be included in this without that. There's still not enough. It's still not rigorous enough by conventional standards, but as they shift their focus on the type of research that's done and we get more and more funding for more and more studies on massage therapy, then we'll continue to grow and be included in integrative healthcare. This definition was written by the Consortium of Academic Healthcare and Integrative Medicine. These are universities that have medical centers that include alternative and complementary healthcare. It was started with about 16 universities. There are now 57 universities in this group, so that's a very good thing. How do we integrate into healthcare? So here's all this conversation about integrative healthcare, and yet massage therapy doesn't always show up in the hospitals, in the medical centers. We are still mostly sole proprietors working in individual offices, clinics, studios. So how do we make sure that we get included in this? And certainly, as this image portrays, our patients talk about what we do with them and their health care to their physicians. But that doesn't necessarily mean that they understand what the patient's talking about. So one of the most important things is that we have some common language and we share communication formats. So our client health records become absolutely critical in integration. If we're not using the same language, then we're not going to be understood. So we all should be keeping our SOAP charts. And I use SOAP chart because that's the most common format for healthcare. I know there's a lot of other formats out there. All of them are fine, but I really think it's important to use a language that's very similar and familiar with the other healthcare providers that we're interacting with. So I really promote SOAP as a format for charting, but please know that really all the other ones out there use the same information. It's just a different format. We all must understand research, so we have to be able to talk about our practices as being evidence-based. And remember, it doesn't all have to be evidence-based, that really evidence is about a three-legged stool. It's what the research data says, it's what our experience tells us, and it's what our patients are requesting. So those three things all come into play when we talk about evidence-informed or evidence-based practices. But we do need to be able to read the research. We need to be able to find it on the internet, to read it, to understand it, and to figure out how to have that information inform our clinical reasoning. So we'll talk about that today as well. The mindset also starts in training in these medical schools. So they're becoming familiar with us is really important. The Potomac Massage Institute on the East Coast has been very helpful in integrating conventional and massage therapy treatment. They have had medical students come to their massage school and take classes. Their massage students have gone to the medical school and participated in those classes, and you know, sharing that environment, I think, makes a big difference. So as much as we can infiltrate the medical schools, the better. But really, the consumers are the most powerful force in maintaining our presence in integrative medicine. And I think that gives us one of those activist points that we really want to make sure we're doing if we want to be included in the insurance marketplace with the Affordable Care Act. We need support from our patients to do that. So any letters that they could write about how massage has affected their health care and their ability to be well, stay well, become well, if it's a rehabilitative setting, is very important. And letters from conventional medical providers as well will play a huge part in educating the insurance companies, educating the mass public that massage therapy has a very important role to play in healthcare and healthcare reform. Another way we can really look at this is by looking at the HIPAA privacy and security regulations. Again, these are standard regulations around the world. I've looked at the Australian regulations on privacy and security, the Canadian regulations, very similar to what HIPAA is, although HIPAA is U.S.-centric. But I'll use it as a platform to talk about this. Sometimes I hear people say, well, you know, massage therapists aren't required by law to chart. And if we take that seriously, then we can also say that physicians are not required by law to chart. There's very few laws around the country, in the U.S. at any rate, where there are specific laws on what type of format or what type of information must be included in physicians' chart notes or any healthcare provider's chart notes. However, there are a great deal of laws on how we take care of those chart notes, how we protect them, how we disclose the information that's on there. So I think the people in regulatory boards are assuming that charting is a standard of care, that everyone charts, that it's not something that needs to be dictated by law because it is a standard of practice. However, how you keep those records confidential and secure is dictated by law. So I looked at HIPAA as just another confirmation that, yes, we should all be charting every client interaction. I think the other excuse for not charting is, well, I don't bill insurance, so I don't have to chart. But if healthcare includes wellness and prevention as well as rehabilitation, then really, as a healthcare provider, we must be charting every session that we have with our clients. So given that, let's look at privacy and security laws. So privacy really dictates the possession of private health information, and the security laws dictates the electronic transmission of those laws. So let's see. So who is responsible for maintaining the privacy? So who is the covered entity? Is kind of the language that's used in this law. And is every healthcare provider, and how they're defining that is anyone who is paid for healthcare services. In addition, they look at who transmits health information electronically. So if you have ever transmitted any private health information electronically, then you are bound by HIPAA laws. And what they are defining as transactions are anything regarding claims, eligibility, inquiries, authorization requests, any referrals that you get from other healthcare providers, and then it says, and other transactions. So we're going to look at that a little more closely. And it also includes if you're sending your bills through a clearinghouse. So it might be that you take all paper records, that you don't have anything stored electronically, transmitted electronically, but you use a billing service that does submit things electronically, then, of course, you are included as well. So how they're defining the other thing, the other parts of healthcare information, is any one of the two things listed here. So if you've got something that has either name, address, birthday, phone number, anything like that, combined with any bit of healthcare information, so what their physical or mental health condition is, past, present, or future, or the provision of healthcare is any type of healthcare. So if it says that they're receiving massage therapy, so you've got their name and the fact that they're receiving massage therapy, and that gets transmitted electronically, then again, you must be HIPAA compliant. So anyone using electronic scheduling systems, or if you're going back and forth about scheduling via email or text message, then all of that counts. Of course, none of it needs to be restricted as long as you take away either the patient's information or the healthcare information. So if it's de-identified, there are no restrictions. So sometimes we think about how we talk about our patients with other people in rooms, if we're in the waiting room and we're on the telephone, or if we're in our office and our door is open, and people can hear us talk about a particular patient, then that's breaking the privacy laws. If, as you can see in this cartoon, the computer is open, so if you're using a computer and another patient's file is up, or the scheduling system is up and they can see other patients' names, if there's other patient files on your desk, if you leave the room and the filing cabinet is in the room and it's not locked and you don't take the key with you, all of those things are ways of not abiding by HIPAA compliance. So there are there are instances where you can disclose private health information, patient health information, without written authorization from the patient. And of course, that is to the individual themselves, and you're actually required. If they ask for any information, you're required to disclose it. If Health and Human Services asks for information, you're required to disclose it, but you may disclose in other situations. So if you're sharing treatment information with other providers that have referred to you, so it's a primary person in the healthcare team, you can exchange information back and forth without written permission from the patient. To receive payment or reimbursement, if you're submitting a claim to an insurance company and they're asking for chart notes on the patient, you can send those off without written permission from the individual, or anything that you need to if you're in a large clinic and you need that information shared for the operations of your healthcare office. You can do that as well. What's important to note is that you should only disclose the information that's required to convey the information that you need to for treatment or for payment. You never disclose everything if it's not necessary. When you are requested to disclose information outside of those stipulations, the request must be made in writing. There's got to be a date on there with the signature of the patient, when that request expires, and you should be recording who received that, who sends out the information, and what the purpose of the request is, and who's disclosing what information should be disclosed. So make sure that all of that information is accounted for when a request comes in, or you should not fulfill the request. When you're writing your healthcare privacy policies, which must be conveyed to the patient, remember that patients have the right to choose how they're contacted. So you should ask which phone number you can leave messages on, what type of information you can leave. If you send out postcard reminders or email reminders, make sure that that they have the right to choose if that's kept private, like in an envelope, if it's a postcard, that it's an approved email address, and ask for permission to send text messages as well. So make sure the patient has the ability to choose your communication format. So we have to notify our patients of these rights. By law, it's no later than the first visit. So you can do it in advance of the first visit or at the first visit. And you need to receive a signature stating that they have acknowledged that they've received these privacy rights. And the patients need to have access to their files. So everything that's in the patient file is accessible to the patient, and they can ask for copies of that. And you can send electronic copies if that's what they would like, and you'll have to do that in a secure format. We'll talk about security in a minute, or making copies of that and then delivering those to them. And you can charge them some fees for copying and postage. So, you know, they don't want it to be a burden to you, but they want to make sure, the laws want to make sure that it's accessible. I don't know if you know this, but the patient has the right to amend their file. So if they have any sense that the file is incomplete or inaccurate in any way, they can amend the file. So you have to make a note of the information that they think is incorrect, and then you attach additional documents to supplement that information. And then again, the disclosure accounting, so you need to maintain some accounting of any disclosure requests, when you received them, when you fulfilled them, who fulfilled them, what was disclosed and what the purpose of the disclosure was. So security, again, is for how to maintain the electronic information, and this addresses technical and non-technical safeguards. So you need to make sure that it's all confidential, that it's protected, that you are anticipating any breaches of that system, and that all of your workforce is compliant with your policies on this. So I don't know if you remember when there was a great deal of debate about whether or not we could have sign-in sheets in our offices. Some of the larger clinics have sign-in sheets, or also if someone could come out and call a patient's name in the waiting room to bring them back. You know, is that legally complying with HIPAA? And they've worked all that out. That was a little too extreme, so it's really the combination of the client's name and what they're there to receive. So those kinds of things are acceptable. No need to put paper sacks over people's heads. So we need to think about security in 3 categories. So if you have administration, then you need to make sure that they're trained in keeping things safe and that you evaluate those procedures on a regular basis. There needs to be physical safeguards. So again, if there's files sitting out or computers sitting out, you want to make sure that a screensaver pops up very quickly on those computers and that those computers are password protected. If somebody could walk by and just hit any key and then the document comes back up on the different patients, that's not acceptable. So it needs to be password protected. And some things I don't think we always think about is that copy machines maintain files on what was copied. So if somebody then hit print again, whatever had just been copied could be printed again. And so you want to make sure that either the copy machines are in a place where patients do not have access or that they're password protected. The technical controls on the computers, you need to make sure that there are also firewalls on those and that any transmission that you send is encrypted. So if you're sending any emails, there needs to be an encryption software system included, loaded on your system. So all of this leads us to client health records. So we need to make sure that we're not only keeping them safe and secure and that we're keeping health records on every single client that we see, but we need to know what those legal requirements are for charting. So we're going to look at the legal requirements. We'll look at medical necessity. We'll look at treatment planning, which is one of the biggest expectations of insurance. They want to know that we're planning our sessions and our future sessions and that we're not just responding to whatever shows up in the office at the moment. If we're going to get a series of 6 or 10 sessions, then we need to show that we can plan throughout that series. Not that we have to stick to that plan. We can certainly adapt things as things change. But treatment planning is a very important aspect of charting for healthcare and insurance reimbursement. Outcome measures is the other very key thing. So we'll look at a various number of measurement tools that we can use in massage therapy. And then we'll talk about reporting. So how do we communicate with other members of the healthcare team? If we're a part of integrative healthcare, it is a team approach to healthcare, and we need to be able to communicate with everybody on that team. And then finally, we'll look at electronic health records. Electronic health records are becoming mandatory for healthcare providers by the end of this year, 2014. And so where does massage therapy fit into that? Are we a part of that requirement, legal requirements, and what should we be looking for in an electronic health record? So I use the word remedial here because it's a very common word used in Australia. I don't think it's as common here in the States, but it's an interesting word to use. So hats off to Australia here in this line. And we need to be looking at the differences in charting between charting someone who is basically well and wanting to prevent medical complications and someone who has a medical condition and we're treating them with rehabilitative intent. So the minimal necessity for charting includes a health intake form. So we should be gathering health information from a historical and a current perspective with everybody we see, and that is for safety purposes. We need to be able to identify if there is a contraindication for massage therapy or any precautions that we should take, and we can only do that if we ask key intake questions and we write that information down. It's impossible for us to remember from session to session what those precautions might be with an individual. We also need to have specific patient identifiers on every page in a client health record. If any page gets separated from another one, we need to be able to identify who that patient is and who the provider is. So there needs to be provider identifiers on every single page. Patient identifiers generally include a name and a birth date. Sometimes there's an insurance ID number that's attached to a patient, and those are also necessary. Provider identifiers are usually your name, your credentials, and some contact information, whether it's a phone number, email, or a physical address on every single page in the patient's chart. If there's a number of providers, if you're working in a clinic, then a clinic ID is acceptable, but each entry in the client health record should have a signature of the provider that provided that service. The date and time for every entry is critical. So the time could be the duration of the session, if it was a 45-minute, 60-minute session, 30-minute session, or it could be from 1 o'clock to 2 o'clock, so it could be the time. Some countries have really specific requirements around that. I know Canada requires the time, so time in, time out for the service. Regarding treatment, the absolute minimum for treatment must be what you did, where you did it, and why you did it. So what are the techniques and modalities that you're using? Where did you apply those specific treatments, and what was your intent behind those treatments? So for a wellness session, it could be really simple. It could be full body Swedish massage, 60 minutes. With relaxation intent, no medical conditions addressed. So that, along with your intake, your signature, your patient identifiers, and practitioner identifiers, is good. With medical conditions, however, there's much more that's necessary. In the format SOAP, the categories stand for subjective, objective, assessment, and plan. So subjective is really about the patient. So what are their complaints, their symptoms? Did they come with any diagnoses from another healthcare provider, and what are those? And then your subjective measures. So the kinds of measurements that you want to take with a symptom is what is the symptom, where is it, how bad is it, so rate the intensity of that symptom, how frequently does it happen, and when it happens, what's the duration of that symptom, how long does it last. So what is it, where is it, how bad is it, the frequency, duration, and then the onset of the symptom. Is there something that aggravates it? So functional limitations are included in this, as well as symptoms such as pain. Objective information is really from the practitioner's point of view. So what are your assessments, your findings, what's your treatment application, and your outcome measures. So outcome measures from the objective point of view are very current. Subjectively, you're talking about historical symptoms. So you can talk about frequency and duration and onset. From a practitioner point of view, it's really just about the intensity. So if you find swelling, can you measure it? If you're pushing on a spot and there's pain, you know, what's the intensity of that pain? Typically a 0 to 10 scale is used. There are other ways to measure that as well that we'll talk about in a little bit. And then once treatment is applied, are there any changes in those assessments or findings? Does the range of motion improve? How much? Does the trigger point pain go down? How much? So if it's worth writing down, it's worth measuring. So I would say your mantra should be measure everything, go to sleep saying measure everything tonight. Under the assessment section of the SOAP chart, it's typically for prognosis and diagnosis. If that's within your scope of practice, by all means. Oftentimes diagnosis isn't, but prognosis can be. So what are you finding things attributed to, and how long do you think this might go on? But more commonly, and I picked this up from the physical therapy profession, functional goals and outcomes become a very useful thing to include in the assessment section of the SOAP chart. And we'll talk about functional goals and outcomes in a little bit, but really it's about the improvement in someone's quality of life. What are they able to do now that they couldn't do before, and can you measure that? And so much of the improvement in like the triple aims theory that we talked about before, what are we looking for in terms of measurable satisfaction of treatment, improvement in outcomes, is measured by function, by activities of daily living. So a very important part that we can contribute to in our SOAP charts. Plan is about our treatment plan. So what do we plan on doing and why? What's our progression of care over a set treatment length? If we get those 6 sessions prescribed, what are we going to do over those 6 sessions? And what will the client do in between those sessions? So self-care education and the homework that we give them is a big part of that. Something we always need to be cognizant of as we're keeping our clients' health records is medical necessity. So there needs to be 2 things. One, proof of the medical condition, and proof of progress. With proof of medical condition, it's really about the intake form and your SOAP chart, gathering information that substantiates the client's condition. So what are they presenting with, and what do you find when you do your assessment that really demonstrate that the person is actually has the condition that's covered by the insurance plan, or not if you're not billing insurance. Proof of progress is really about you being able to show that your massage therapy treatments makes a difference in the person's presentation of the condition. And again, like I just spoke of, quality of life is absolutely essential to that. So that includes patient satisfaction as well as the outcomes. And much of that can be demonstrated through an increase in function or activities of daily living. This is a treatment plan chart that I use that really helps me think about what I want to do over a series of sessions. So what is the client presenting with? And then what goals might I have about those? So if somebody comes in and they have pain and numbness and tingling in the right neck, shoulder, and down the right arm, then my goal might be to decrease the pain, decrease the numbness and tingling, perhaps increase the range of motion and the function of that. So those are my goals. And then I think about what can I do to help a person with that? What are the techniques that I would use in a neurological condition? So I might think about pain pathways, and so maybe some neuromuscular therapy on the scalenes and in between the clavicle and the first rib to relieve any possible impingements, maybe some kinesiotaping to relieve pressure on the nerve, and I might want to see them once or twice a week in the beginning for 60-minute sessions. The latest dosing study that came out of group health showed that 1 or 2 sessions, 60-minute sessions a week, was most effective, that less than 60-minute sessions were not as effective, and less than once a week was not effective, that we really need to be seeing someone more frequently for longer sessions if we want to get rehabilitative effects. And then I think about, so what do I want the patient to do in between times? Is there a topical analgesic that I want them to use, or ice that I want them to use? Is there's a particular exercise or stretching technique that I want to make sure they do to support the care in between time? So that's how I use the treatment planning chart. So outcome measures with functional outcomes, we've got the SMART goals to help us write good functional outcomes. So we want a goal that's specific to an activity of daily living. So not just a function. So we don't want to say lift, stand, sit, but we want to talk about how much they're lifting their child into the car seat, how much they're walking or sitting, what they're doing when they're doing those things. They're standing at a cash register at work. They're walking upstairs to go up to the bedroom floor. They're sitting working at a computer. So making sure that you're really talking about what's meaningful in their daily life that they're attaching those functions to. You want to make sure that those are measurable goals, that you can quantify something and qualify something. So you always do it in relationship to time or repetitions or weight. So if they're sitting at a computer, that they can sit for 3 hours with an increase of no more than moderate pain in their shoulder and the numbness and tingling down their right arm. And then you assign it a time frame that you're going to be able to accomplish that goal within 2 sessions. For a short-term goal, or within 5 sessions, for example, for a long-term goal. Make sure these goals are attainable. You want to set your patients up to succeed and that they're relevant. You don't pick a functional goal that they don't do every day. If it's just a periodic thing or something that they haven't ever done but they want to do, you don't set a goal around that. You really want to use your functional goals to describe things that they do on an everyday basis. Here are some other measurement tools that we'll just quickly go over. We're starting to run out of time here, so I want to just briefly go through some of these measurement tools with you, but also let you know that there is a website with lots and lots, dozens and dozens of measurement tools divided up by categories. There's physical evaluation tools, there's mental health, there's functional tools, all kinds of tools are available to you at this website. It's a Canadian-based website that NCAMS funded, and I use it all the time. It's a fabulous resource for you. So some of the most popular measurement tools are here. I'll give you a quick look at all of them. I don't have the hospital anxiety and depression scale on this, but there's so much research that demonstrates that massage is effective for anxiety and depression that we may need to start measuring that. So visual analog scale, it's similar to the 0 to 10 scale. This is actually 10 centimeters long. They'll make a mark on the line, and you can actually measure where that is and record it as a number out of 10. But with value statements here instead of numbers, it's a little more reproducible and reliable according to the research. So I like to have a visual analog scale used on a periodic basis. The functional rating scale kind of combines numbers, an analog scale, as well as value statements. And there are 10 of these, and there are numbers from 0 to 4, so it's a rating over 40. So 4 times 10 is 40, so regardless of which number they circle, you would add them up and put that over 40. The specific function and pain scale gives the person the ability to write in what activity is most important to them and then rate it on a scale of 0 to 10. For this one, 10 is their ability to perform the activity with absolute perfection. And then this is the inability to perform the activity. So it's kind of the reverse of the pain scale. This one's much more complex. They have all these value statements that they can check. Again, there's 10, and they can score up to 5 out of each, so 0, 1, 2, 3, 4, 5. So out of 10, 50 points possible. You could multiply that by 2 and get a 100% disability scale if you wanted to use it that way. But I find this very helpful if you need lots and lots of detail on your disability rating scales. So measurement tools should be used initially and then periodically to demonstrate progress. So you don't have to use them every session. Communication, we should be reporting to our other members of the healthcare team. There's initial reports, progress reports, narrative reports. Initially, you just want to say, hey, thanks for the referral. This is what I found. These are our goals, and this is my treatment plan. And then after 4 to 6 sessions, you write a progress report and say, this is what we've accomplished. And if you want to continue treating the patient, then this is what our treatment plan is for the future, with a request to ask for additional prescription for more massage. A narrative report really is from beginning to end. So you're narrating the entire treatment, doing kind of a compare and contrast. So electronic health records are really only mandatory by January 1st, 2015 if you're Medicare eligible. So no one in the U.S. is Medicare eligible. Oregon is now Medicaid eligible. So we'll look and see if that's a requirement for them. But I think it's important, if we're going to communicate with other members of the healthcare team, that we use the same communication devices. The nice thing about electronic health records is it makes them accessible across healthcare clinics. So it's really about increasing access and helping increase the accuracy, decreasing the duplication, coordinating care, those kinds of things. So it's a great thing. I think all of us should be considering moving towards electronic health records. I think for the massage professions, it's really going to have to be a fast and easy system. Most importantly, I think it's going to need to be customizable. There's so much variety in the massage profession, and there's no one tool that can really accommodate for all the variation in the different bodywork disciplines that exist within massage therapy. So customizable electronic health record is going to be very critical with built-in measurement tools. So I just showed you all those measurement tools that we can use, and we should be using those. I think our records mean very little if we can't measure progress. It's absolutely critical. So these are what I'm looking for in an electronic health record, and as I build an electronic health record. So that's my recommendation to you. And really, I just want to thank you very much for taking the time to really look at massage therapy as it finds a place in healthcare reform. and as we need to comply with our privacy and security issues and how we keep our paper and electronic client health records. So thank you very much.
Thank you so much, Diana, for that very informative presentation. You went into a lot of detail and shared some really good information that therapists can use right away. I think it's good to understand all about the electronic communication and the privacy around how you can keep your notes and information private and exclusive, respecting the laws and having that knowledge. It's very important for therapists to know about that.
Yes, I agree.
So I'm just going to thank you for joining us today. I really enjoyed this presentation, and everybody has your information for contact if they need to get in touch with you for any further questions. Thank you so much for your time. And I'd also like to thank our sponsors. We'd like to take a moment to thank our global sponsor, Massage Envy. Massage Envy is committed to supporting your profession. Massage Envy has donated to organizations that promote the healing benefits of massage and careers in massage therapy. Visit massageenvycareers.com and click on the Giving Back tab for more information. Massage Envy, more of a culture than a company. And thank you to our education partner. Associated Bodywork and Massage Professionals provides an extensive array of member benefits and exceptional liability insurance. Visit www.abmp.com to discover why over 80,000 massage and bodywork professionals have chosen ABMP as their professional association. And thank you to our daily sponsors, Massage and Bodywork Magazine, Massage Today, BioFreeze, and Bon Vital.